we can be extremely excited about the next panel. This is Medical Practitioner Burnout and Resilience, and we've got a phenomenal group of scholars here to assist us. So I'd like to go ahead and let you know who they are, and then we'll go ahead and bring them up to actually start their presentations. Christina Maslach, Professor of Psychology at UC Berkeley. Many of you know her incredible work and gigantic body of work involving the Maslach Burnout Inventory. How many of you have used that inventory in this room? I think that's a good indication as to the importance of the work that she's done. We have Dr. Eve Ekman, a postdoc at the UC Osher Center for Integrative Medicine as well. A wonderful person, looking forward to hearing her work as well. We have Laura McClelland, an assistant professor at Virginia Commonwealth University, a professor of health administration. And at the end, Mandy O'Neill, who's also an assistant professor at George Mason University, which, just to let you know, is in Northern Virginia, just in case you wanted to know. Sounds good. So without further ado, can you please join me in welcoming Christina Maslach up to the podium?
Well, thank you very much for inviting me to come. And I realized as I was listening to all of the talks this morning and this afternoon that some of what I have to say connects really well with a number of points that people came up, but I want to also put a slightly different angle on it in terms of talking about people who are working in healthcare. And we've been talking about how they might have compassion, or better, more compassion in terms of families, in terms of patients and whatever. And I, in a sense, have a theme of the compassion we need to have for the people who are the staff and the employees of these institutions. So the problem of burnout, just to refresh your memory on this in case you need it, the exhaustion, the stress that people feel, the cynicism, the negative take this job and shove it attitude that begins to develop and has important implications for the quality of care or the lack of quality, and a sense of I'm really not doing very well here, professional inefficacy. So what we're really talking about in other terms, overwhelmed, unable to cope, unmotivated, negative attitudes, poor performance. This is something that we're seeing in many occupations, not just healthcare, but that's what I'll be talking about today. So as a reminder, this is based on a lot of research across occupations as well as healthcare. Absenteeism. If you're feeling burned out, you get out, whether you leave or whether you don't show up for work, particularly in healthcare. This is a major issue. Poor quality of care. We've been talking about that. Incivility, how we treat each other on the job. Turnover, leaving, not staying. Health problems. It is a stress response, and so we're seeing the kind of health outcomes that we would expect. Leading into depression and future problems, and as has been mentioned before, higher costs for organizations. So this is why we care about it. It used to be that people would say, well, why do we bother about burnout? I mean, so somebody's having a bad day. I mean, big deal. I'm running a hospital or, whatever. But it's these kinds of costs, social, financial, personal, that are really important. This is why it makes a difference and we need to do something about it. So let me talk specifically a little bit more about in healthcare professionals. First off, there's probably been more work done on burnout in healthcare than just about any other occupation that's been studied. Many have been studied, but still, if you look at the percentage of different kinds of studies, people getting involved, it's healthcare, physicians, nurses, radiologists, all kinds of people that work has been done on. And what I'm pointing out here is the more specific findings of a number of studies, just to sort of underscore why this is such an important problem. Poor quality of patient care, more medical errors, dysfunctional relationships with colleagues, and I'll come back to that in a few minutes, greater risk of substance abuse, and we're finding this on longitudinal studies, greater risk of depression, suicidal ideation, and a stronger intention to leave the medical profession. And this has been growing, as previous speakers have been pointing out, at quite alarming rates. So here's just a couple of recent findings, just to sort of say, where are we today? Online survey of almost the 7,000 physicians, about half are reporting at least one symptom of burnout. And I think that's where people were saying half the physicians. Be a little careful. They may not have full-blown burnout, but they're on their way in the sense that they're beginning to really show some important signs. 2014 study, medical students, residents, early career physicians, they were compared to people who had advanced degrees in other professions as the comparison group. They have much higher burnout rates than other people do. 2012 study, over half of primary care physicians age 50 or older plan to leave practice within 5 years, as did 30% of primary care physicians ages 35 to 39. The intention to leave, and even if you don't leave, that we've found that the intention gets reflected in how you do your job. In a sense, you're not always there the way you should be. And then finally, a recent survey, national survey, that found that only 1 of 10 physicians would recommend medicine as a career, okay? Now, this may not be just because of burnout, but there's something basically going wrong here in our healthcare system, in our, that we're having these kind of things beginning to happen. So I want to frame this as, because this often gets posed to me, is it the person, is it the people who become surgeons, who become doctors, who go into nursing? Or is it something about the situation? And I want to quote from 2 people who have been doing a lot of the work on burnout in healthcare. And these are recent articles that they've pulled together. The first one from the Mayo Clinic. The fact that almost 1 in 2 US physicians has symptoms of burnout implies that the origins of this problem are rooted in the environment and care delivery system, rather than in the personal characteristics of a few susceptible individuals. And then Anthony Montgomery, I've just started this year a new journal on burnout research, open access e-journal, and I am able through this to sort of commission new articles. And I asked him to write about physicians and burnout based on the fact he's studied physicians in many different countries, and right now is running a study in the EU in 8 different countries. And he wrote an article on the inevitability of physician burnout. It's an inevitable consequence of the way that medical education is organized and the subsequent maladaptive behaviors that are reinforced in healthcare organizations via the hidden curriculum. Thus, burnout is an important indicator of how the organization is functioning. So basically, if you want to frame the question that way, it's the situation seems to be carrying a lot more of the variance. What is going on when you take good people, smart people, well-trained people, and put them in an environment where they all begin to somehow fade and not do so well? So should we fix the person or the job? If you look at all the work that's been done on interventions of different kinds, unfortunately the research is not always that good. They often lack control groups and so forth. Fixing the person, yes. Fixing the situation, more rare for people to try and do that, but it tends to be more effective. Better to fix both. And what I really want to say is, let's not get into this adversarial thing, but really look at the person in the job context and pay attention to the job context, because we don't really tend to do that. As I do work with people in healthcare, it's not that they don't have motivation originally and meaning in their work and, all of these kind of things, and compassion. The system really sucks their soul and takes it out. And so in some sense, we have to say, what do we do about that system rather than keep throwing people into it, have these problems, and then we have to patch and repair? And so that's really my big message on this. This is an example of something that's being done with nurses now. It was developed by an intervention developed by the Veterans Health Administration. It's called CREW, Civility, Respect, and Engagement at Work. It's a 6-month team process to build a supportive work community. It's because the nurses came and said, one of our big problems here is this toxic social environment that we work in. And some days we just don't want to come in. And so this intervention, we've been, my colleagues and I have been sort of gathering data on how well it works. It actually, after 6 months, and it keeps going for a year and now a year and a half, proved civility, better ways in which people treat each other, show respect, learn how to resolve conflicts, make better decisions. Burnout goes down. And we asked for one behavioral measure at least, and that was absenteeism. And absenteeism drops dramatically as a result of this kind of intervention. So even though people say, well, how can you change the environment? It's possible to take some aspects of it and make it better. And you see those changes happening. So I give this as an example. That's workengagement.com if you want to find out more about it. This just underscoring the research that's done with controls and a very significant impact that is lasting quite a long time and more than the one-day workshop. And then what I'd like to point out is what we have found in the research, if there's anything you remember about the talk I give today, other than just the focus on we need to look at the environment and the surrounding system as well, is these 6 mismatches between job and person. Because that's where we have found these are predictive of burnout if there's mismatches. If they're working better, you see greater engagement with work. So this is one everybody thinks about. Too much work overload. Okay, but often you don't have much control or discretion or say about what you do. You're not getting sufficient rewards. And we're not really talking so much about money and benefits. It's often social recognition that you did a good job, that you made a difference, and not hearing that. Breakdown of community, this is the workplace community, so this is the social relationships. This is what the CREW process is about. It's about those social relationships and beginning to go awry, and that we're not working well together within this, that really ups burnout and as I say, it's possible to change it. Absence of fairness in terms of who makes decisions, who gets benefits, who gets promoted, who gets special assignments. Value conflicts. If you feel that you're doing something that just goes against the grain of how I should be behaving, what I really want to accomplish here, and so forth. So when you think about, these are the 6 areas, one or more of them can be causing problems, and this is really where we try and structure interventions to see what we can do about it. But let me just leave you with sort of the example of having compassion for people working in healthcare. When you have compassion for something else that you want to thrive and grow and be beautiful and be wonderful, you don't think just about that person, or let me take the example of a plant. Maybe you want something beautiful to grow in your front yard. What do? You create an environment that really promotes the best that they can bring, that really allows them to grow, innovate, do good things. You give it good soil, you give it water, you put it out in the sun rather than in a dark closet, all of this kind of thing. We need to be thinking about our human resources, all of us who work in institutions, to say what would be the best way to create an environment that achieves the goals, in this case of healthcare, and does it by actually considering the health care and benefit and growth and accomplishment of the people who are delivering that, rather than having a system that really sucks your soul. So it is possible. We see ways of making changes in healthcare and other institutions to begin to do that. It's a big challenge. There are many ways of doing it. No one-size-fits-all solution at all. But we need to have that piece in this whole puzzle to really think about, if we've got such a bad system that is burning out so many people, we have to figure out ways to change that system. Thank you.
And just as a reminder, Dr. Maslach's the editor-in-chief for Burnout Research. So if you've got some great research that you're looking to submit, this would be a great place. And if you're looking to research or do the reading in this area, that'd be wonderful as well. So next, if you can welcome Eve Ekman up. She'll be talking about stress, turning stress into meaning.
Thank you so much. It's a real pleasure to be here. I definitely thank our moderator here, Dr. Martin, and Dr. Doty, and everybody at CCARE for organizing this event. But I also just want to take a moment to thank everybody in this audience. I'm sure many of you are missing days at work. Can I get a sense of how many people in the audience are providers, either in healthcare or schools? Thank you so much for being here. I know taking this time out is quite a big deal in your busy schedules, and I really hope that we can give you some ideas and inspiration to keep you going in the meaningful work that you do. So to give you a sense of what I'm going to cover today, I'm going to give you a little bit, sorry, missed one there, of background. I'm going to tell you a little bit about this lens that I'm going to look at burnout through, which is a lens of empathy and meaning. I'm going to give you an idea of some past studies I've done, not exactly in a hospital setting, but with human service care providers, and tell you where I'm going next. So as you got a small preview, this is a picture of my previous normal work day. I was an emergency room social worker at San Francisco General Hospital in the emergency room for 6 years. And I didn't take these photos with my phone, so no HIPAA violations, don't worry. This was actually from an article published in the Chronicle, a paper here, about the kind of difficulty and challenges of this work. Anybody who works in a hospital setting, especially an emergency room, knows well, this is a very challenging place, quite literally life and death. However, it was absolutely no holds bar, the most meaningful work I've ever done in my life. And it was definitely not the paycheck that kept me coming back every day. And in fact, the conditions of work there, I felt often that I was closest to some sort of purpose, some sort of kind of state where I was at an optimal ideal. I was very interested in what allowed myself and my colleagues to show up every day with integrity, to really be showing up for their patients, helping out and connecting, how that motivated them and allowed them to deal with some pretty stressful situations, not simply once in a day, but throughout their entire shift. I was also interested in my colleagues who clearly were showing some signs of and symptoms of burnout. As Dr. Maslach, who I was very fortunate to have on my dissertation committee, described so well, there's many different aspects of burnout. There can be an aspect where we feel exhausted, an aspect where we feel lack of efficacy or meaning, and one in which we become simply cynical, the kind of not my job phenomena. Being around your colleagues in this way can be as detrimental as the work itself. So when I went back to school, I was really interested in kind of what allows us to manage the more difficult situations in our everyday work environments. This quote, I think, is worthwhile to examine for someone who we know dealt with about as difficult situations as anyone can imagine. And yet, as many of the providers in the room, I don't need to tell you, when your work feels meaningful, it also feels like you can keep going. You can really manage through the day-to-day. So when I went back to start looking at this phenomena of stress, this phenomena of empathy, I was interested not only into individual impacts, which we know so much about from a great deal of stress research on the psychophysiology mentioned this morning in other research, but what it does in terms of our immunological functioning, as well as our social emotional connections, our relationships with others. But what impact does this have on our coworkers when we come to work with not a whole lot to give, let alone on our clients, patients, or students? So I'm going to show you a little here from my studies, and the way that I started my study was really thinking about empathy, not simply as we have for our friends and for our loved ones, but a professional empathy, one that informs our behavior and response. And earlier this morning we had Dr. Zaki giving us a definition of kind of empathies in a way, the different ways in which we can experience empathy, but he also said that we have that kind of immediate emotional response. We see someone suffering, maybe they are visibly in pain, maybe they're telling us about their own experience of fear. We have that autonomic nervous system arousal, reminds us that someone is upset, and we are rallied to respond. Then there's the cognitive appraisal. Well, what then do we do? How do we do this? How can we manage it? What we know from a lot of research is, in fact, that appraisal, that ability to recognize our own experience of emotion, can really be helpful in our ability to manage and maintain those emotional experiences. Again, for the providers in the room, you know that everyday empathy is not necessarily even a choice. It's something you manage and you kind of figure out your own way to build these important containers, these ways we have boundaries through our emotional response. But this appraisal can really help and inform a behavior that might be compassion, it might be setting a limit, it might be a whole host of other and variety of important ways that we interact with our clients every day. So I'm not going to go over this since we know quite well, but suffice to say there are 3 different levels of burnout that are working here. And importantly, just to look at that exhaustion every single day and how we manage stress is a lot of understanding and being able to manage our emotional arousal. What are we becoming upset about? Why is it upsetting to us? So here I have this very simple illustration. And again, Dr. Zaki was talking about this a bit this morning, this sympathetic distress. When we feel that we can't help and that anxiety that we can't help another person who's in distress becomes overwhelming to us. However, on the other end of empathy, in addition to making us feel maybe distressed, we can feel profound connection and meaning, purpose. Dr. Cole mentioned this just briefly at the end of his talk. Where does meaning exist in the body? Is there a place we know that it can actually help us manage through stress? This is what happens when we kind of are losing our ability to feel empathy. We start with a core motivation of why we do this work, to help others. We find meaning from that, but unfortunately we become exhausted over time by simply giving more than we actually have available to us. And many of the myriad reasons that Dr. Maslach was describing in terms of how hard the work demands can be, how overwhelming our role can be. We start to feel a lack of efficacy, and we withdraw emotionally, simply too hard to engage. However, when we withdraw emotionally, we also are losing that capacity for meaning and connection. What would happen in an ideal setting is we'd have our job role, and from that, things would flow quite lovely. We'd have our motivation, that would allow us to have empathic communication with our clients and coworkers. We'd feel satisfied, we'd feel that meaning, again, going back into our motivation. We don't have time to go into why there's so many ways in which this gets a little stymied, but we can hopefully have time for questions for that later. So for my research, I was interested in looking at human service care providers, and that for me includes hospitals, jails, and schools. I decided to work actually in a juvenile jail setting in San Mateo. I had spent some time as a social worker there and knew that the officers had an enormous amount of time to spend with these kids who needed help maybe more than anyone else. I chose this Cultivating Emotional Balance, which is an emotion regulation and mindfulness practice, as a way to start doing a training for the guards in this setting. So here we are in San Mateo Jail. You have many youth there who are held from up to 2 weeks to up to 6 months. They are with these guards 24 hours a day, 7 days a week. And I wanted to see what were the sources of stress and opportunities for empathy among these guards as human service care providers. So I did a simple observation study, kind of sat around in the jail hanging out with these guys, realized the ER is still the worst place to work in the world. Then adapted the CEB study, which is a 42-hour study, set up a lot like mindfulness-based stress reduction, as many of you know in the room. So it's a long study over 42 hours. I wanted it to be 16 hours, and then I piloted it in this jail setting. And I don't have much time to tell you about the study, but I'll give you a little sense of what my observation showed me. My observation showed me that people described a lot of stress. They described the kind of stress that made them feel numb, that made them feel removed from the work they did. He said, I say probably 4 days out of the week, I'm just numb. I don't even hear my conscience, I'm just numb. And so describing that level of stress was definitely motivating for me and to try and figure out a way to help. However, one of the other things I observed sitting there was being with these guards behind the locked doors. I would see that they had this phone right in the middle of their desk, and it seemed like the only time that the phone rang was when it was a kid who'd already been released from jail, was calling back in to talk to one specific guard. He wanted to say, it's my birthday, I'm doing well in school, this happened or that happened. So it was clearly an opportunity for connection and empathy happening in this setting. So basic hand wave to data. Here's the people. They were people who'd been there quite a while. People who'd been in this job over 8 years. They planned on staying a long time. This is an important point to me. It's not that people get stressed out and leave their jobs. They get stressed out and they still stay because of financial reasons and otherwise. A tiny little story here is that I found that there was 2 separate settings that I did my research in, and this illustrated well this point of how connection can be so meaningful. In one setting, there was very little connection with the youth. There was electronically locked doors, the youth were kept inside almost the entire day. In the other setting, there was no locked doors at all. In fact, there weren't even cells. This was a place in which relationships were needed in order to manage the behaviors of these youth. So in this more kind of open setting, this camp, people had a higher feeling that their work mattered. There was a sense of purpose. This is quite literally more work, but they had also more connection. Whereas in the other setting, people just felt that they were institutionalized too. They were locked up. So I did this pilot, which was a stress study. Some people thought they were coming in for actually a stress heart rate examination, but in fact, we gave them a couple days of basic emotion regulation skills in terms of identification of an emotion felt in the body, identified in the face, over the timeline of their own experience. We did mindfulness-based exercises including compassion, loving kindness, reconnection to meaning and motivation, psychoeducation on burnout, and also basic communication skills to enhance empathy, both with coworkers as well as with the youth themselves. People found the training to be beneficial, to be useful for them. They said that the breathing, that anchor, that ability to relax and be able to see things was especially of use. So now I am at UCSF at the Osher Center of Integrative Medicine, and have to say that it's a wonderful place for those of you who don't know it. There's a lot of people trying alternative modalities there of how we can have a bigger vision of healthcare. And though I did my previous study in criminal justice, I'm now going to return to hospitals, be working in the Department of Pediatrics, and one day in the future would love also to bring this to schools and leave you with this quote of empathy as a core competency. This is not something to the side. This is not a training that we opt into, but how do we really get this into basic medical education? I know there's a lot of you in this room who agree with this, so thank you again for your time.
Thank you, Eve. Next, if we could have Laura McClelland come up, and she's going to be talking about building the business case for compassion.
Thank you. Thank you so much. It's a treat and a privilege to be here today. So special thanks to CCARE and Dignity Health for creating this wonderful conference. I'd like to take this opportunity to talk about some of the work I'm doing with my colleague Tim Bogus at Vanderbilt University on compassion practices. We're really interested in trying to understand how is it that healthcare organizations can create conditions that enable and sustain compassion on an everyday basis. We know from all of the different panels that we've heard from today that compassion is critical in caregiving, that high-quality care is compassionate care. And so many of our speakers have talked about the wonderful benefits of compassion to patients in terms of positive health outcomes, improved patient satisfaction. And some research that we've done has also shown that when hospitals regularly use practices that reward and reinforce compassion, that support their care providers, they also have higher patient experience scores. So I don't know how many of you in the room are hospital administrators, but HCAHPS is kind of a hot topic right now. I hear some chuckling. That's because of value-based purchasing, for those of you who aren't familiar with it. It's been a significant change. Now CMS is tying hospital reimbursements to these patient experience scores. So while we know that compassion is so important for patients, it now has direct financial implications on the bottom line for hospitals. And what we show is this link between compassion to not only benefiting patients, but also to benefiting organizations. But we also know that the work itself, and this is what this wonderful panel is talking about, it's important, but it's hard. There are high incidences of stress and strain as a result of the work, but we're humans. We bring our whole selves to work, even when we don't want to. And all of those things can really get in the way of providing high quality, compassionate care. And so it begs the question, how is it that healthcare organizations can create these conditions that enable and sustain compassion? And what we hope to show today briefly is that the answer, one of the answers, is in compassion practices. So what do I mean by compassion practices? They are these repeated actions and concrete practices that encourage and foster and support workplace compassion. Dr. Duffy described Code Lavenders. The article was recently written up in the Huffington Post, where a nurse was quoted as explaining, well, it's like a code blue, but it's for the human spirit instead. We see examples in many hundreds and hundreds of hospitals across the country that are now utilizing Schwartz rounds, ways in which to bring together clinicians to talk about the non-clinical aspects of a difficult case, ways in which these organizations are trying to help providers cope with the difficulties and the demands of the work itself. So while we know that these practices exist, and while we know that there is this link, this empirical link between the usage of them and HCAP scores, these patient experience scores, we still know very little about them. And so we decided to conduct a qualitative study looking at 2 large acute care hospitals in a city in the southern part of the United States, Mercy Hospital and University Hospital. We conducted semi-structured interviews, non-participant observation, and looked at archival data. And we have some interesting findings. Compassion is alive and well. And what we see are 3 kinds of practices that we think really contribute to creating these conditions. The first are what we call these sort of infusing practices, ways in which the organization provides itself with new members who are likely to express and show compassion on the job. The second kind are these sustaining practices. The sustaining practices are so critical because they reinforce the appropriateness of showing compassion to patients, to family members, but also to colleagues, to one another. So bringing in resources that are likely to show compassion, but also reminding them of the importance of continuing to do so. But we don't stop there. What we see are evidence of practices that are restorative practices, these replenishing practices that really are these regular ways that help healthcare organizations restore the well-being of employees. So what they do is they help them in order to improve their ability to provide high-quality care. And so I want to show you what they look like. I have a few examples of each type. And so what we see are examples of these infusing practices across both hospitals, and they oftentimes tended to manifest in hiring practices. So this quote here comes from the chief nursing officer of University Hospital, and what she describes is how they use a common set of behavioral interviewing questions. But as part of the interviewing questions, what they are looking for is the likelihood that new hires, new employees, are going to show compassion on the job. And so what she says is what we look for in those answers is the giving of themselves, the warmth, the understanding, and the empathy. So really trying to select people into the organization to infuse the organization with workplace compassion. The second example is an example of a sustaining practice, and there were many. We saw evidence of them in the use of rewards practices that rewarded compassionate behavior. But I wanted to highlight how both of these hospitals utilized common training practices to regularly remind employees about the appropriateness of showing compassion on the job. And so what these practices do is they very much promote and routinize the noticing, feeling, and responding to the suffering of others. So the example that I have here is from the director of hospitality services at Mercy Hospital. And what he explained to me is that every single time they had a new hire orientation, he would go to it and he would stand up there and he would say to every single person in the room, I want you to take yourself back to a time where you felt like you had no control over anything. And remember that every single time you interact with a patient. And what he's doing is he's reminding all of the employees in the hospital, frontline, back office, to engage in that perspective taking, to engage in empathetic concern in order to help provide customized, compassionate care to patients and family members. The last examples that I have for you are examples of replenishing practices, and I have 2. These are regular ways that the organization directly tries to support healthcare professionals who are suffering, who are experiencing hardship. The first one that I have is a way in which both hospitals use their payroll practices to facilitate ways in which employees could compassionately support and respond to the suffering of their peers. This example comes from the director of food services, and she's describing some of the folks that worked in the cafeteria. And she says, they'll donate. That's the policy. Everybody does it. I had one girl donate 80 hours to a person who had lost a limb. because she knew she needed it. 80 hours of PTO, that's 2 weeks. That's a lot, indeed. But it's a way in which the organization is providing a way for employees to customize and respond to their colleagues' suffering. The second example I have for you is a way in which organizations are using these replenishing practices to directly attend to the suffering that's caused by the workplace itself. Both organizations deployed a number of staff support personnel, and in particular, using their chaplaincy program. This quote here comes from the director of staff support at University Hospital. And what she says is that she oftentimes gets called up to a unit that's had the 11th death in 20 days, and she goes up there to do a debriefing with the staff to find a way to ritualize their grief. You can't come into healthcare and it doesn't impact you on some emotional level. So regular ways to directly attend to the workplace suffering that employees experience on a regular basis. And so what I hope you see here is that these compassion practices are a great opportunity for all of the healthcare practitioners here in the room. There is a great potential to take everyday common organizational practices and allow them to become these vehicles for the expression of compassion and the maintenance of compassion on an ongoing basis. They are expansive and flexible, allowing members and organizations to nimbly respond to the needs of patients and family members, but to also take care of their own. Thank you.
And the last panelist, Mandy O'Neill.
Hello again to some of you who've been with us for the week, and thank you so much for your presence and your compassionate audience participation. I've seen so many head nods and so many smiles, and that really is great for those of us up here who know that we're preaching to the choir a little bit. So today I'm actually going to show you some new research that we've just started writing up, in addition to giving you the overview of where my collaborators and I are coming from in this research, which is the study of companionate love in organizations, and specifically in healthcare organizations. I want to first acknowledge my collaborators, Dr. Sigal Barsaid at the University of Pennsylvania. People have said of Sigal that she anchors the positive affect scale, so she's just one of those collaborators that brings a lot of joy to the work. And also Francesco Seguro at Católica University in Lisbon, very similar to San Francisco, actually, if you get a chance to get out there. They have a wonderful business school. So my background is as an organizational culture researcher. So really looking at the organization as a system comprised of deep assumptions and artifacts. And I'm going to walk you through how organizations can actually focus on all of those to create stronger cultures of love and why it matters. When we think about culture, the metaphor that some of us like to use is of an iceberg. I actually saw another iceberg today, so I think there are a lot of iceberg metaphors here, which is the idea that culture is manifested at a topical level, which we can see whenever we enter an organization. We see artifacts of culture, and I'm going to show you some data on the importance of artifacts. But culture actually goes much deeper. So beyond the artifacts are the values and the beliefs that sometimes employees can articulate, and then at the deepest level, the one that's hardest to get at, is the level of assumptions, the most taken for granted aspect of a culture. Today's focus is going to be the culture of companionate love, which includes compassion and also some other emotions, including affection, caring, and tenderness. So not just focusing on suffering, but just simply the affection we feel for coworkers, the tenderness that leaders show for their subordinates sometimes, and the caring that we feel for one another. Like other emotions, it has distinctive physiological sensations, subjective experience, cognitive appraisal, and behavioral action tendencies. But importantly for the workplace, companionate love is a fundamentally other-oriented emotion, and it is shaped by the social context. And it's very important for our purposes, again, because we're talking about culture. So we want something that's subject to the contagion effects that we see in all emotions, but particularly in the workplace, to complementarity, to reciprocity. this model is derived from a prototype model of emotion. So for those of you who are thinking about your organizations, imagine that your organization could actually be comprised of many, many emotions, including these 132 or so that Phil Shaver and his colleagues identified. We're focusing on the left on love, but I'm going to show you some data that actually organizations are multifaceted, and cultures can actually be comprised of multiple emotions. So sometimes you'll have love, and sometimes you'll also have anger and fear and sadness. And today I'm going to show you some data about what happens when you look at those emotions together in interaction with one another. I don't have to tell you this probably, that healthcare is a world of emotions. So it's a great place to start, and there's obviously a lot of work we need to do too. So the first study I'll just give you an overview of is a large study that we conducted in an urban long-term care facility and hospital in the Northeast. And this is, in some ways, this presentation is a tale of two hospitals, because this is a hospital that was already considerably higher in terms of the average job satisfaction and tenure of its employees. And the CEO essentially welcomed us in and said, but we want to be even better. So we're going to give you access to everything you want. We're going to get a team to support you in doing this work. We want to be an even stronger, less of a clinical model is what they were interested in. We called it more of a culture of love, as it turns out. We were able to look at this organization and be inside of it longitudinally, so we could see the effect of variation in culture over time on multiple outcomes. Importantly for our purposes, we had a very robust measure of organizational culture of companionate love. One of the things you've heard today is that employees can be very cynical when they feel like this is just another tagline, this is just another poster. It was very important to us that we were actually capturing the culture at all of those levels, including, I want to point out, culture of love artifacts, which in this setting meant artifacts that reflected warm, close relationships. And for many of the patients who had dementia or who'd been away from their homes for a long time, it was a reflection of a time when they were in these warm relationships. So it was objects around the units that reflected some personality, pictures, knickknacks, tablecloths. For the staff, it involved green in the organization, so plants. There's some very famous research in our field on the importance of taking care of plants, but actually in this case, plants, colorful tablecloths, they evoked warmth, which was critical to the culture of companionate love. We also had insiders and outsiders who were on the units. So these are people who not only knew their own unit, which most employees can say, but these are people who traveled among units and could really see the variation. This did involve some rather complicated statistical analysis, multi-level analysis, because you had employees who were nested in units. And I should mention, one of the interesting things about this panel today is you've gotten a nice sample of employees, not just the CEOs, not just the doctors, not just the nurses, but actually top to bottom of the organization. And some wonderful examples earlier of how food service workers, janitorial staff, these are all people who affect the patient experience, and they're co-creators of the culture. So when doing these kind of interventions, it's important to look top to bottom. We looked at a wide variety of measures, but given this is a panel on burnout, and I want to focus specifically on emotional exhaustion. And particularly, I want to, kind of draw your attention for 1 minute to the idea that, we're all on the same page here, but for many people, one of the reactions we get to this work is like, yeah, no duh, okay, culture of love's good, yeah, we get it. I want to point out from the perspective of the literature, it's not so intuitive, and I'll explain why in a second. What we found is that workplace relationships are deep enough to sustain cultures of love. So in the strongest units, we saw relationships that are family-like. And they could be recognized by insider-outsiders, not just people who are very deep. Importantly, and this is the counterintuitive part, what we saw is that strong cultures of companionate love reduced emotional exhaustion among the staff. Now, why is that so counterintuitive? Well, if you actually go into the emotions literature, what you'd see is that a lot of the research shows that asking employees to express emotions that may not be what they genuinely feel actually increases burnout. So our findings suggest that when you have a strong culture of love, what you actually see is the opposite, that it reduces burnout. But much of the literature in this regard suggests that asking employees to do anything else on top of their job, especially if it involves more work, in this case emotion work, is increasing exhaustion. And we actually find the opposite when it is deeply integrated into the culture. I want to show you just a brief finding about the other type of hospital. So, based on this work, another hospital system said, wow, we want you to come in, and boy, we need some work in here, because it turns out not only had the city where this took place experienced a serious natural disaster, but actually had just recently got written up as one of the lowest one of the lowest percentiles of quality of care in the nation. So they had some very, very big problems, including all the problems going on in the healthcare industry right now. So we did get support to come in and do a large survey of the employees as a baseline for future culture change. What did we find here? First, we were able to survey not just the medical center, but also the medical school, which sometimes has a complicated relationship, and sometimes the incentives of the practitioners are not necessarily aligned. So we did get all of these employees. It was a very large-scale survey. We measured not just emotional culture, but also the typical culture that is talked about in terms of achievement orientation, innovation, terms you've probably heard. We wanted to say that, you know what, emotional culture matters differently than the way we've been talking about it. We were focusing particularly on the culture of love and the culture of fear. We looked at employee outcomes, including meaningfulness, job psychological safety, optimism, and importantly for our purposes today, emotional exhaustion. What did we find? What you see here are the results for culture of fear. When culture of fear is weak, you see, not surprisingly, less emotional exhaustion. When culture of fear is strong, you see very strong burnout. These are the results for when the culture of love is weak. Let me show you what happens when you have a strong culture of love. What you see is that bar to the right went down, and I'll show you them together. What this shows is that fear is never good. We know that. But when you have a strong culture of love, what you see is that it actually attenuates the negative effect of a culture of fear in organizations. So we're not going to necessarily make the fear or anger or sadness go away, but when we have a strong culture of love, it reduces its effect, in this case on employee burnout. So this is not to say, by the way, that culture of love is going to exist and it's going to rule out all the emotions. They're still going to coexist, but when you have them together, you can actually reduce some of the negative symptoms. So what do we do about this? Top management. It's very important to focus on emotional culture alongside the other measures of culture we've been talking about all along, particularly achievement orientation and innovation, which are things that come up a lot. Managers, our findings and the work of others has shown that leaders role model these emotions very, very strongly. So the same person expressing emotion, if the person's a leader, it's going to have a much bigger effect on the employees. Model those emotions that you want to create. HR, make sure you hire the right people. We do find these cultures have a stronger effect on some employees. Bring the employees on that you want to create that culture. And lastly, employees, we've seen some great examples today of how compassion can be cultivated through small acts of compassion. Thanks so much for your time, and look forward to chatting later.
Okay, in the interest of time, why don't we open up some questions to the audience? Does anyone have any questions? Yeah, over here, all the way in the back.
Hi there, so I'm from England. I work with the Student Wellbeing Service at the London School of Economics, and this is just a question for Mandy. Where do I start if I want to get a culture of love going in my organisation? Little old me on my own. What first steps can I take? Because we know the talk, but the reality of my organisation, my university, is that there isn't much of a culture of love.
Yeah, well, that's a good place to start. Is you can only go up from there. I would say one of the things is getting top management support, at least to do the work, helps a lot. So sometimes if you're a lone change agent, it can be done, but it helps a lot if you have top management support. Also, to be able to really do interventions, I'd say. To be able to start to do this, employ the scientific methods that we've seen today in terms of the hard sciences and social sciences, start employing them in the organization. So to create designs that allow for that, I think is a very, very important next step.
Just continuing with that, what are some of the examples of, acts of compassion or the things that you're trying to institutionalize? Like, can you list some of the actual behaviors or?
I think that the panel could probably talk about this, not just me, but one of the things we observed is that it happens in both the formal practices and also the informal. So, for example, when you're dealing with trauma cases, one of the things we notice is that some people have a hard time asking for help. So in Strong Cultures of Love, they instituted a formal practice where anytime there was a particular code, a response, or a sort of care support counseling team was automatically called down. So they didn't require people to make the extra step of recognizing recognizing they need help and asking for it, but they actually just were automatically called. It became protocol. In another example, we saw, for example, a policy in which anytime an employee had a significant death in the family, the CEO was automatically notified. And so that person could express compassion to the employee. And again, building these into the practices, and I think the rest of the panel, especially the qualitative researchers, probably have some fantastic examples on the ground.
So in addition to these more formal practices, a lot of data that I didn't have the opportunity to show you, I had these wonderful stories of compassion that were more spontaneous acts of compassion, that because the organization really encouraged the noticing of suffering of employees, what you would see is these spontaneous acts where, these cafeteria workers would notice that a colleague of theirs needed new shoes, and they would pool their money and buy them a new pair of sneakers. There was a group in housekeeping where they found out that one of the housekeeping staff, she was sleeping on the floor because her grandchildren had moved in with her, and they got together and they bought her a mattress and a comforter and a pillow, and she now sleeps in a warm bed.
I would just give, is this mic on?
Yeah.
Okay. I would just give a different approach to your question, which is kind of the interventions that I've been looking at are about the individual learning to develop their own practices. And that's not irrespective of the environment that you're working in. As Dr. Maslach was saying, it's so important, the environment. However, we don't have a whole lot of control over the environment. Thank God for the people in the room trying to make that change at the administrative level. But when you're going in and just trying to do some basic training, it really has to do with an individual practicing these skills of emotion regulation, being able to understand, identify with their experience of emotion, and giving them other practices, kind of targeted mindfulness meditation practices. As Chuck Rezan was saying earlier today, not simply mindfulness, but maybe a compassion-focused practice, or maybe there's another practice that at the time, you have to have some empathetic joy that will help people. So having a whole toolkit, and a lot of it isn't sitting quietly because most people don't have the opportunity to do that. So what are the ways, especially through technology, we can assist people to help develop habits that allow them to kind of ease and relax as opposed to tighten and constrict against the daily stress?
Yeah, I can sort of add up on all of these things here. The crew intervention that I mentioned is an important part of that, and other interventions we've seen that work well, is when you really get all of the people who are working in the institution or in the different units together, working together, identifying what would make a difference for them. How could this place be better for us? And it means they have to talk to each other. They have to identify with each other. The way this thing happened in the ER yesterday was just, really demeaning in terms of how this happened, and how could we do it differently so people, correct it, but, don't feel badly about it. And it takes time and practice, but in general, change, social organizational change in these kind of organizations comes about because people believe in the change and say this is important and I will do it. If you have anything that comes in top down saying, okay, everybody is going to say this today, they're going to drag their feet sometimes and not do it. So they have to be a part of the process. They have to have input, and they have to, in that sense, take ownership around this. How are we together going to make this particular unit a better place to be? So I'm looking forward to working here rather than, taking a deep breath before I come in. What about touch and hand holding? Yeah, again, everybody else can sort of speak into this. I guess what I'm saying, I think, is that there has to be some sort of a social norm around the group that we all feel comfortable with, and explicitly, this is great. And being able to get a hug, or a pat on the back and all this kind of thing would be great. But again, you have to realize that sometimes for some people that's crossing a boundary that's going to be uncomfortable. So again, this is it's great to raise possibilities and ideas and sort of say, how would we feel, or how would you feel, or how, so that you can actually tailor it to what would make the group really feel more comfortable and engaged and trusting and supportive and willing when they see somebody who's feeling distressed to feel that I can ask and say in a way, is there something I could do? And maybe it's a hug and touch, and maybe it's something else, but there could be a variety of ways. But you might want, I don't know if you want to speak any more of that.
It's funny you mentioned hugs, because that comes up a lot in very different ways. We had one, in the DC area, we have a huge amount of defense contractors, and so you wouldn't necessarily think there's a lot of hugs, but there's one subdivision that was known for its culture of hugs. And at first, when senior executives showed up, they were completely freaked out, but then they finally realized that, well, that's how they express a culture of love there, and we're just going to let it thrive. But it's very important to echo that love manifests itself differently in different environments. So if you take like the most macho culture, it may not be about hugs, but they may use the metaphor of family, and that's how they describe affection. So it's very important to tailor it to the context.
It looks like we've run out of time, so maybe we can hold some of these questions to a little bit of a after conversation. But thank the panel for a great conversation, and we look forward to
Wonderful, wonderful.